Hello everyone, this is Mrs. Catlin. This is chapter 1 of pharmacology. Just to get you started, the first test will cover the first unit, just the basics about pharmacology, some things about herbs. It's not real in-depth, just some basic material. So you can take notes during this. You might want to print it out ahead and take notes however you want to do it. And I'm just going to record and click as I go. Okay, so 3 drug action phases: pharmaceutic, pharmacokinetic, pharmacodynamic. Everything goes through at least 2 phases. The pharmaceutic, the one with the 3 phases, is when you take medication by mouth. We're going to go into that a little more in the next couple of slides. Okay, number 1, the pharmaceutic phase. This is when you take a tablet or a capsule, something that has to be dissolved, that is not disintegrated or in a liquid form. You take it into your mouth. %80 of medications are taken by mouth and have to undergo this first pharmaceutic phase. So if you ask the 3 drug action phases of an oral medication, it's going to be these 3: pharmaceutic, pharmacokinetic, pharmacodynamic. Now the pharmaceutic doesn't occur if you don't take it by mouth, if you take it parenterally. Parenteral, if you break the word down, para means other or besides, enteral means intestine. So if you take any medicine in a form that doesn't have to go through the intestines to be absorbed, it is parenteral and doesn't go through pharmaceutic phase. So the medicine breaks down as the picture shows and gets disintegrated until it's dissolution, which makes it into a liquid form. It needs to be in this form to be able to cross over the biological border or into the GI tract, intestines, and then into the bloodstream. Medications of this form, not all of this is medication, has fillers called excipients. There are different kind of fillers and ingredients that help the medication disintegrate and then dissolve. Most medications, not all, but most medications dissolve well in an acid environment that you find in the stomach. Back up here. Aspirin is acetacetic acid, so it will really burn the stomach. So it's often enteric coated, so it doesn't break down so easily in the stomach and will break down later in the GI tract, where it will not be so irritating or damaging. Anytime you have a medicine that is enteric coated, or if it's in a capsule form, there's a purpose for that. Like a capsule might have little like pebbles, marble type medicine inside. Do not break that capsule open. The whole purpose of it is so that that coating or capsular outside is to keep it from being broken down at that point, and breaks down lower in the GI tract over a certain period of time to make it a time release. Of course, the longer it takes a medication to dissolve and absorb, the longer it's going to take for that medication to reach effectiveness. A liquid not having to go through the first phase, this pharmaceutic phase, will be absorbed a lot faster than a tablet or a capsule. Okay, next slide. Pharmacokinetic phase. I thought this was a really good picture. Study what body does to the drug. It is a study of absorption, distribution, metabolism, excretion. This is the way I remember it, ADME, the fate of the drug. I say it as ADME. To me, ADME means you're adding that medication to you. It's the absorption, absorbing it, distributing it, metabolizing it, and excreting it. ADME. Like this little cute thing. How is this stuff going to get down from there, up there, to my sore throat? to this. So a lipid soluble, if it's going in to a fatty environment, it's a fat soluble drug. It's going to be soluble into that membrane very easily. But if it's a water soluble, it's going to need some sort of carrier or energy to bring it across. Okay, let's talk a little bit here about this first pass effect. Most medications, when you take them, ingest them orally, they're going to go first pass through the liver to break down. And depending on how much breakdown occurs in the liver is how much of that medication is left over. There's some medications like lidocaine, nitroglycerin, which we'll get into at a later time, that are never given orally because they are broken down so rapidly in the liver that they're not going to have enough medication to have any effect. So the first pass effect is the medications going through the liver. Medications that are given in a different route, such as like in the muscle, intramuscular, will not have to go through that. They're going to go through the muscle to be absorbed and absorbed much more rapidly. Bioavailability. That's easy if you think of a bio as living life, available. Once it's broken down, once it goes through its first pass effect, if it does, then how much is available to be actually used by the living thing that the medication was administered to. Not sure how much exposure you had to administering medications at this point or in the lab, but you will notice, if you haven't, start to pay attention that you're not going to give the same dose intravenously or intramuscularly or orally, where you might give some meperidine or Demerol IM by mouth or IV, where by mouth you might give them 100 milligrams. In the muscle, you might give 50 milligrams. IV, you might give 20 milligrams, because right in the vein, you're giving it directly intravenously. You're taking away this breakdown, and you're going and making it 100% bioavailable if you're giving it intravenous. Another thing to think of in this first pass with the liver breaking it down, if you have a poorly functioning liver, some sort of hepatitis, liver failure, or an elderly person whose liver function has decreased, that is also going to affect the first pass effect, and it might make more of the medication still available, not having been broken down completely in the liver. Here's another note. Affected by absorption is affected by the drug form, the route of administration, the GI mucosa and motility, food and other drugs, changes in the liver caused by liver dysfunction or inadequate hepatic blood flow. I think I covered all of that. Remember, with the GI mucosa, as you get into the small intestine, you have a little thing called the villi of the intestines. Think of them as like little hairs that move things along. And if that's damaged, they have some sort of infection, they've had a small bowel resection, something like that, there's not as much surface area or villi to help with moving that medication or help with absorption, which also affect that absorption. Medications, I talked about the lipid-soluble medications. If you have protein-based drugs such as insulin or a growth hormone, those are often destroyed by the digestive enzymes in the GI tract. So those are some medications that you'll find are okay. So the second part of ADME is distribution, the way the drug moves from circulating body fluids to its site of action. Obviously, these are the things, as we've been talking about, which are going to affect absorption. I thought this was a good diagram. So protein binding If it's bound to the protein, it's got to break away from the protein to be absorbed. Blood flow, the greater the blood flow to the area of absorption, the more rapid it's going to be absorbed. Body tissue affinity, whether or not it likes it. Oh, yes. Blood flow, let's go back to blood flow. Things that affect blood flow can be pain, stress, hunger. Body tissue affinity can also be affected by your pH. Volume of drug distribution is all these things when they go through the initial phase absorption, the first pass effect, the pH, whether it's water soluble, protein bound, lipid soluble, whether it has a coating, was it in a liquid form, all these things, and then you get in and you're looking at the blood flow, the hepatic function, the absorption rate by that tissue, all leading to the amount of actual drug that is distributed, and that will affect the overall pharmacological effect. And as I mentioned, if you give it intravenously, you might be absorbing, make 100% of the drug administered actually bioavailable, whereas through all these other factors going through the GI tract, it can be as low as 20 or maybe just 40% of the actual bioavailable drug from the initial oral dose. So it can be, the oral dose can be 3 to 5 times greater than a dose that you want me to go to that slide yet. Okay, let's move on. This is just a picture showing the absorption across from your textbook on page 6, showing crossing the blood-brain barrier and drugs crossing the placenta. The blood-brain barrier, which of course where you'd want medications such as the anticonvulsants, which are protein bound. So the blood-brain barrier is a semi-permeable membrane that protects the brain. Only drugs bound to protein or highly lipid soluble are able to cross. That's why anticonvulsants, which need to work in the brain, will be a protein bound medication. Placenta, lipid soluble and insoluble, are able to cross the placenta and infect the fetus. This is one of the things we'll get into just a little later, I think near the end of this chapter, talking about the ratings or categories for pregnancy. Okay, so the ADME, we did absorption, distribution. Now we're up to the M, metabolism or biotransformation, the process in which a drug is converted by the liver to inactive compounds through a series of chemical reactions. This P450 is an enzyme found in the liver. There's multiple ones. You'll see certain ones that need particular enzymes in the liver to help them absorb. Is this biotransformation, conversion from one chemical form to another. The site, as mentioned here, is often in the liver and needs certain enzymes to help break it down. The effective metabolism, 80% of the drug may become inactive through the liver enzymes in the liver. The inactive part of the drug becomes active or prodrug. Some drugs do not metabolize at all. They're excreted exactly as they were taken in. This picture goes through a few of them. This is showing you the first pass. If you look at taking medication in, going through the portal vein in the liver and how much of the medication is metabolized and how much becomes available. So the drug is swallowed, goes through the digestive system, the first pass in the liver, and then distributed out to the remainder of the body. So by the time it gets through this, there's not that much left of that actually gets out to the body unchanged. And as I mentioned on previous slides, things that affect the first pass effect of the drug in here is enzymes of the whole GI tract coming down, the gut wall enzymes, bacterial enzymes, and then the hepatic enzymes. So first pass is all the way through the GI, through the liver, and then ends with whatever becomes bioavailable. The last of ADME, ADME, is excretion or elimination. The drugs, prodrugs, resultant drugs, unchanged drugs are excreted or eliminated through all these facets. Majority goes through the kidney. I wrote in here creatinine clearance, that is the main one. Creatinine clearance is something you're looking at when you look at your labs. If you haven't been looking at them when you're in your clinicals, even if you're not sure what they mean, just get used to looking at lab results on your Chem 7, or no, they call it now a BMP, basic metabolic panel, is your basic 7 enzymes. So it's a BMP, we used to call them Chem 7s or SMA 7s because there were 7 things in them. They do not give you your liver enzymes, they give you your basic electrolytes, sodium, potassium, chloride, glucose, CO2, BUN, and creatinine. So your BUN and creatinine are telling you about your liver function. I mean, not liver function, your kidney or renal function. And then you'll see something called GFR. More and more labs are showing, and they don't always do them unless it's ordered. You may not see it as often in the hospital, but what I've noticed a trend on GFRs or glomerular filtration rates being listed on things. Those are a great thing. You want it over 80. Most people are over 100, and you start seeing a creatinine clearance of 70, 60, especially 50, 40, you're in trouble. So they're not going to clear as well and not going to eliminate all of that drug, which increases the risk for toxicity or buildup of a drug. Your liver will break things down, and your bile, you've got the bile going in your gallbladder. Your bile is a way of eliminating your feces or your stools, your lungs with your CO2 release, any of your body fluids like your saliva, your sweat, and breast milk. As mentioned earlier, we'll be talking about the ratings for pregnancy and categories for being able to take certain medications. That's another factor, is looking if somebody is breastfeeding, whether or not that medication is excreted in the milk. Do they need to, what we used to call, when I worked in family practice, we called it pump and dump. Okay. Now, more pharmacokinetics. Almost forgot. Half-life. The time required for the body to eliminate 50% of the drug. That is half of the life. I always think of it kind of as the peak, like you take a medication, and when it reaches its maximum amount in your body, bioavailability and effectiveness, and then the half-life is the next, when you reach a half-life and it's at this amount, and then the next half-life is how much, when that cuts in half, and that 25% is left, when is that, 50% of that. And anyway, main half-life is when it reaches its max and starts to come down. Your book gives examples of 2. That has a table that goes over the half-life of aspirin And then in its paragraphs, it discusses the difference between that and the half-life of digoxin, because one having a very short half-life. Here, the half-life of aspirin on your table, if you take one aspirin, it takes 3 hours to eliminate, or the half-life is 3 hours. So within 6 hours, it's down to like a fourth of that, as compared to digoxin or lanoxin. Let's see here, which has a 36-hour half-life. So 36 hours or 3 days after taking a dose of digoxin, half of that medication is still there. That's one of the drugs they will give a certain amount of doses to build it up in the body, and then put them on a maintenance dose, which is something we'll learn as we get more into medication, just understanding why some medications are given that way, why some will have a loading dose, why some have to be given every 46 hours, why 24 hours, why once a week, all contribute to this half-life of the drug. This is a chart that I found that I think helps. This is your first pass. When you swallow the drug, you start to lose some of it in the acid throughout the GI tract, the intestines, portal system, which is that hepatic vein going into the liver and then going out to the circulation or your bioavailable. So that's when it goes through its first pass. This just use the size of the tablet in the image to show you how it shrinks and how much actually is bioavailable after it reaches its site. Now, pharmacodynamics, that's the third drug action phase. We had pharmaceutic, which is anything that's taken orally, pharmacokinetic on all medications, on how it's made into action. Now we're going to get into pharmacodynamics, or the study way drugs affect the body. The primary effect is what you're hoping for. The secondary effect may or may not be desirable. Most undesirable are side effects. Sometimes there is a desirable, or you might hear the term at some point called off-label use. That's not something you will have to understand if you choose to go on further in your education later and decide to ever have prescribing privileges. You will have to understand this, and that's when there is a side effect that actually may be beneficial to some people, and that's when a medication is used as off-label. So the drug action is the cellular process involved in the drug and cell interaction. The drug effect is the physiological reaction of the body to the drug. I'm going to say that one more time. The action is the cellular process involved in the drug and cell interaction, and the drug effect is a physiological reaction of the body to the drug. Okay, so when we talk about pharmacodynamics, we have to talk about the onset, the peak, and the duration of action. As noted here, the onset is the time it takes for the drug to elicit minimal therapeutic response. It doesn't mean it's at its peak, at its most. It's when it starts to have some therapeutic response, or the response you're looking for. Peak is the time it takes for the drug to reach its maximum therapeutic or highest plasma concentration. That's I always think of as the half-life, when it gets all the way up before it starts to come down. Duration is the time the drug concentration is sufficient to elicit therapeutic response. So if you're taking a pain medication and it's ordered every 6 hours, they may start to feel some relief at 45 minutes. At 2 hours, they're feeling really good. 3 hours, it's not as much. 4.5 hours, there's just a minimal. Their pain has gone. It had been a 10, it went all the way down to a 0. It starts to come up, and they're at a 5, and at 4 hours, they're saying their pain is back to a 6, and by 6 hours when it's due again, the pain might be a 10, something like that. I hope that makes some sense. And I use an example saying the pain gets to a 0, but we don't always achieve 100% of what we're hoping for. We just are looking for the lowest amount of drug necessary to reach the maximum desired effect from that medication. So we have to understand the time response relation to the drug administration. If the drug plasma or serum level decreases below the threshold or minimal effective dose, and dosing is not achieved too high a drug level above the minimal toxic concentration can result in toxicity. So we have to be careful looking for a certain effect, but not going to the point where it's going to cause. We're looking for the highest effect with the lowest dose, with the lowest side effects or potential for danger. Okay, things that affect the pharmacodynamics or action of the drugs. Receptors or drug attachment. The drug binds to a receptor to initiate a response or block or prevent a response. And as we later go into different kind of medications, we will have agonists, ones that kind of, I say it, chemical fits at the receptor site. It's eggs them on. I think of an agonist as egging them on. It helps, it fits and helps that chemical work. Partial agonist, chemical blocks another chemical from getting to the receptor. So you have two medications or two things that want to have a chemical reaction at that receptor site. A partial agonist blocks something else from reaching there so that this one can attach. Antagonist is is against, attach the receptor, but only produces a small effect. The drugs act on different receptors. Some don't have specific receptors, they're called non-selective. A variety of responses result from action at these receptor sites. Drugs that produce a response but do not act on a receptor site may act by stimulating or inhibiting enzyme activity or hormone production. Here's a picture of the receptor theory: agonist and antagonist. Weak agonist, well, I told you the agonist is exit on. It really attaches to those receptor sites. Weak agonist, it's not real good at attaching. So here, two drug agonists attach to the receptor site. The drug agonist that has an exact fit is strong agonist, more biologically active than the weak agonist. This one fits lanky key. The better the fit, the better the action or desired response. This is just a picture to give you some ideas. Non-specific, where it doesn't have a specific receptor site. So like this particular drug, non-specific, doesn't have a particular receptor site. You see that it affects multiple locations: eye, heart, blood vessel, stomach, bronchus, bladder. It doesn't just target one place in the body, so that you have multiple responses throughout the body. Here's another with non-selective drugs, epinephrine, which we'll get into in a later chapter. And it has receptors in the alpha, beta 1, and the beta 2, which affect different parts of the body, have different effects here. So those effects can be good or bad depending on what you're looking for. Like here with the beta 1, increases heart rate. If you have somebody whose heart is damaged or their heart rate's already 90 or 100, do you really want that side effect that you may be looking to get their blood pressure up, but can they tolerate their heart rate going up? Or they're having an asthma attack and you want to relax the bronchioles, but they have a heart condition and they can't tolerate this. Categories of drug action. Stimulation or depression. The drug that acts to stimulate the rate of cell activity or the secretion from the gland increases. It may act to depress it. The cell activity and function of a specific organ are reduced. Replacement replaces essential body compounds. An example would be insulin. Inhibiting or killing of organism. The one that comes to mind for me is antibiotics or anti-against bio-life, but it kills those unwanted organisms. Irritation can act as a mechanism of irritation. One of those is like a laxative. It irritates the wall of the colon to stimulate the peristalsis and get it to evacuate itself. Drug action can last for hours, days, weeks, or months, depending on the half-life of the drug. I touched on the therapeutic results. The therapeutic index, it measures the margin of safety of a drug, is a ratio that measures the effective therapeutic dose and the lethal dose. Some have a very low therapeutic index. It's where it's a very narrow margin of safety. The drug effect should be closely monitored. A high therapeutic index has a wide margin of safety and carries less risk. When I think of therapeutic index, I think of certain medications such as like digoxin. It has a very, very small therapeutic level. And some of the anticonvulsants that you're monitoring, some have a wider range, some have a very narrow. But digoxin, I think the 2 is, can't think of the levels right now, but we'll get them in a more. But just to know the therapeutic index, the wider that margin, the more room you have. If it has a very small therapeutic index, you want to monitor that level closely. Sorry, it was bugging me once I mentioned digoxin. I couldn't think of the level. I was saying the max of 2. I had to look it up because it bothered me. 0.5 to 2 is what you're looking at for levels there, which is not that high of a range. In your text, it gave examples of the anticonvulsants on page 10, which is one of the ones I mentioned that's often monitored because it does have a therapeutic index that you don't want to go over, and that range varies a lot depending on which of these medications. That therapeutic range is your therapeutic window, the window where you are safe. Peak and trough levels. Okay. Go back to therapeutic range. Your window is a level of drug with minimal effectiveness and minimal toxic concentration. As I mentioned earlier, you want the lowest dose with the highest effect and less poor effects, ill effects, or damage. Peak and trough levels. This is something, if you haven't been exposed to, you will, at least after graduation. Peak and trough levels will be ordered. Peak is the rate of absorption drawn shortly after the drug is administered. There's theophylline. I know they got away from it for a while. That's one of the medications you do peak and trough. And certain antibiotics like gentamicin is one of the ones where you're going to do a peak and trough. You want to do, because the range is not real long, wide, you want to make sure you're hitting that peak where you're getting a good rate in the body. And then the trough is the rate of elimination, and it's drawn before the next dose. It is the lowest plasma concentration, and gentamicin is the biggest one that comes to mind because of the therapeutic index. It's one of the ones that you're monitoring. That's one of the things that you have to really watch for when you are actually working. If you're on something that will have a peak and trough, you want to look to see which dose, like it might be your 3rd or 4th dose of something that a peak and trough is ordered. And that's where you have to watch your orders, because you'll have gentamicin and do a peak and trough at the third dose. So hopefully it's being marked on your MAR, medication administration record, which is going to be your third dose, so that you know to draw your peak and troughs. You're going to get your trough before you draw your dose. Before you hang your dose, it's going to be IV. And then you're going to hang your dose, and it's going to be so much time after the drug, usually 30 minutes. A lot of times it's pharmacy that is actually ordering it. The doctor might order it, or provider, and have pharmacy dose it. It'll be written like that. So they'll do the dosing, and pharmacy will come through, a pharmacist will come through and write those orders on certain doses of these things. So that's something to look for, mark, and make sure you don't hang that dose before you get to draw the trough, or you're going to be on the phone making phone calls, and it doesn't feel real good. You will do it, because I've done it. Okay, loading dose. I mentioned loading dose earlier when I was talking about digoxin. It's one of the ones I'm very familiar with doing a loaded dose on. It's used when immediate drug response is desired, a large initial dose to try to get a therapeutic concentration. Side effects are known and frequently experienced effects of the drug. Everything's going to have its side effects. Adverse reactions are not desirable. They're unintended. Adverse are always reportable. Side effects are not necessarily reportable. Adverse are ones you really don't want to happen, and those are ones you're going to report. An adverse effect could be something like red flushing of the skin, severe aches, a medication that causes vomiting, something that's severe, and it's always reportable. Toxic effect, of course, is obviously reportable. It's a result of excessive pharmacological effects, such as seizure medications, certain seizure medications, which can cause liver failure. Now, adverse effect, undesirable and reportable, but it's due to a normal dose of the medication that causes these adverse responses, which is different from a toxic effect, is when the dose is too high, or the body cannot metabolize or excrete it, and becomes toxic to the body. Multiple reasons this can happen. I just remember myself many years ago working home health, obviously exposed to tuberculosis at some point, had a positive PPD skin test, which you've had your skin tests. I've been working for many years, always getting the test done. First time was positive, freaked me out. I had the test done again, and sure enough was positive. Had to go to the health department, do the x-rays, make sure I didn't have tuberculosis. I'd just been sensitized because I was exposed. They put you on medication in INH. They put you on it 6 months prophylactically to hopefully kill the TB that's running around the body but has not become active. I am missing a particular enzyme. It's not the most common 340, but it's one of the enzymes in the liver that my body obviously was deficient in. So when I took the INH, within 3 weeks, my body couldn't break it down in that first pass, so it accumulated as bioavailable in my body, and within 3 weeks I was toxic and was beginning to shut my liver down, had to get off the medication. So there are multiple reasons. It's not that why you can end up being toxic levels in someone's body. Here, pharmacogenetics, scientific discipline studying how the effect of the drug action varies from a predicted drug response because of genetic factors, hereditary influences. I don't know if mine is a genetic or hereditary. Anyway, an example, African Americans do not respond as well as Caucasians to some classes of antihypertensives such as ACE inhibitors, which we'll talk about when we get into them, which like lisinopril and okay. Tolerance and tachyphylaxis. Tolerance refers to a decreased response over the course of therapy. That's one that you will see commonly with different opioids, pain medications. After a time, the body becomes tolerant, and you need to increase the dose to receive the same therapeutic response. Tachyphylaxis refers to a rapid decrease in response to the drug. Think of tachy, when you get into cardiac things, you think of a heart rate greater than 100 as being tachycardic, tachy being rapid, phylaxis is that response. So rapid response, rapid decrease in that response to that drug. Drug categories that can cause this rapid decrease in response, again, are like the narcotics, barbiturates, laxatives. Somebody that gets in the habit of using them all the time is why you try to tell them not to do that. And psychotropic meds, that's why people with bipolar or schizophrenia medications have to be adjusted, tweaked, moved around. Placebo effect, psychological benefit from a compound that may not have the chemical structure of a drug effect. So you give a medication and somebody has a different response, you know it's not the medication itself that actually caused that, but the person psychologically feels like that's the response they're getting. It's effective in approximately 1/3 of persons who take a placebo compound. Isn't that interesting? 1/3, it's a lot. Okay, phases of drug action. The is just a review. The pharmaceutics, pharmacokinetics, the ADME we talked about, pharmacodynamics, which is that actual action. Nursing process. I'm sure you've heard this. Everything is on the nursing process. Assess, diagnose, plan, intervene, evaluate. To me, your diagnosis is what you see as your problem. The old thing I always remember, we used to do charting called API charting, which they don't do anymore, but I like to think of the nursing process that way. I assess what is my problem, I make a plan, I intervene, I evaluate, and then we have APR, APIER, where you assess, plan, intervene, evaluate, and then do the process again and reevaluate. Determinants that affect drug therapy. This again is just a little summary. If you're thinking again of your nursing process, your assess, plan, intervene, and evaluate. These are all the factors you're going to keep in mind when you're thinking of different aspects of your assessment, what it's related to, how you'll intervene, and how you'll evaluate it. Okay, and that is the end of chapter 1.